there, everyone. So today I'm going to talk to you about celiac disease and what I think is hot in the world of celiac. So we all know that celiac disease is common. It affects about 1 in 100 individuals in the UK and globally. And we also know that celiac disease is on the march. We're seeing increasing diagnosis in places such as India and China, and that's probably due to a number of factors such as westernization of diets. But despite this, we still know that 3 out of 4 individuals are still undiagnosed. But I suspect in the years to come, you're going to see more and more cases of patients with celiac disease in your clinic. So I'm going to touch on some of the things that I think are hot in the world of celiac disease. So these are the topics I'm going to talk about over the next half an hour or so. So the first thing that I'd like to talk to you about is biopsy avoidance. So some of you may already be familiar with this, but these are the pediatric guidelines for the management of celiac disease. And what you'll see is there are a certain subset of children who actually don't need biopsies. So these are children who've got symptoms such as anemia, weight loss, or diarrhea. They have positive blood tests, so they have high levels of TTG, so more than 10 times the upper limit of normal. And they also have positive endomysial antibodies and positive genetic typing. So if all of those strict criteria are met, then they can be diagnosed with celiac disease without a duodenal biopsy. So that really leads us on to the next topic, really, is that can we avoid biopsies in adults using the same approach? So at the moment, we're still biopsying everybody with adult celiac disease. And you might ask, well, why is that the case? And I think there are a number of reasons why we might consider that. So those are some of the that I've listed here on this slide. And I'd like to bring you to focus on a couple of these things. Firstly, doing biopsies allows us to assess how severe the disease is. So you can actually see whether there is mucosal damage using a duodenal biopsies, which you can't see using blood tests. Also, a lot of these patients with celiac disease have red flag symptoms. So by that, I mean they may have anemia or weight loss, and they may need to have a gastroscopy anyway to rule out other sinister things such as cancer. So if we're doing a camera test anyway, why don't we just take biopsies? And the other thing to mention is that in adults, gastroscopies are better tolerated than in children. They don't need general anesthetic, and even though they're not nice, they are easier to perform. So why am I talking about the benefits of avoiding biopsies in adults? Well, I think that the benefits really are twofold. Firstly, I think this will benefit the NHS if we can avoid biopsies, because we don't need to do any more gastroscopies for celiac disease, so that reduces waiting lists and saves money, and we know that we're in tough times in the NHS. But more importantly, I think this would benefit patients. Now, I put it to you really. What would you rather have, a blood test, or would you rather have a camera shoved down your throat? I'm sure most of you would actually prefer a blood test, and I think that avoiding this may reduce the anxiety and discomfort for patients who are newly diagnosed with celiac disease. So the question is, does this actually work in adults like it does in children? So this is some of our data here from Sheffield, where we looked at newly diagnosed patients with celiac disease in adults. And the interesting point from this study is that if we used TTG values of high levels, so more than 10 times the upper limit of normal, the pickup rate for villus atrophy, or changes suggestive of celiac disease, was 100%. So you can see that from this data, this is quite compelling to suggest that maybe some adults actually don't need biopsies. And it's not only Sheffield that's suggested this. There have been other studies being performed in Italy and Finland, and there's actually now a large international study being led by Professor Ciacci in Italy looking at biopsy avoidance in adult celiac disease. So I suspect that in the future, we may have a subset of adults that actually don't need biopsies. So the next area I'm going to talk to you about is something called potential celiac disease. So potential celiac disease is kind of this grey area that you might see in clinic when you're reviewing patients. So these patients have positive blood tests, so positive serology, but then they undergo a biopsy which doesn't confirm the diagnosis of celiac disease. So these patients are kind of in the waiting area that they haven't got confirmed celiac disease, but they may eventually develop it. And the question really is in clinic, what do you do with these patients? Do you give them a gluten-free diet, or do you just continue on a normal diet? So I'm going to show you some data looking at this with regards to using a gluten-free diet in individuals with potential celiac disease. And this study was from a few years ago that they looked at individuals with established and potential celiac disease, so about 70 patients or so. And what they did is that those with potential celiac disease, so those with positive serology but not confirmatory biopsies, they were randomized to either continue on their normal diet or to be randomized onto a gluten-free diet. So they followed up all these patients over a year period. Now, these are the results, and it's quite difficult to see, but I'll try and explain these things for you. So if you look at the top left-hand corner, so graph A, so this is looking at changes in the lining of the small bowel. So you have three distinct groups. So you have the gluten group. So these are individuals with potential celiac disease that continued on their normal diet. You then have the gluten-free diet group. So these are individuals who have potential celiac disease that were randomized onto a gluten-free diet. And then finally, you have the control group, which is the celiac disease group, who went on a gluten-free diet as per standard care. And what you'll see is, if you focus on that middle one, you'll see that there's improvements in the lining of the small bowel, or improvements in histology on a gluten-free diet. There was improvements also, if you look at graph B, in endomycin antibodies and tissue transglutaminase antibodies, and also symptoms. So it appears from this data that individuals with potential celiac disease had improvements in histology, serology, and symptoms. Now, you might ask me, well, how about those patients that had potential celiac disease that just continued on their normal diet? What actually happened to them? So again, if we focus back on graph A, the gluten group, you'll see that when they actually had a normal diet, their histology worsened. And again, that was the same for all these other features, such as serology and symptoms, things that didn't improve on a normal gluten-containing diet. So I think my take-home point from this really is that if you see patients with potential celiac disease, I think you should give them the option of whether they want a gluten-free diet or not. And there certainly is evidence to suggest that it may work. So the next area, so they're on the diet for 1 year. So the next thing I'm going to talk to you about is adherence and how we assess adherence. Now, adherence is challenging. I mean, from my own personal experience, if I have a course of antibiotics, I really struggle to take all those tablets. And you can imagine, if you have celiac disease, you have to maintain a strict gluten-free diet for life, which isn't easy. And this is a cross-sectional survey in patients with celiac disease. And what you can see, if you look at the green part of that pie chart, is that only 3 out of 10 patients were strictly adherent to a gluten-free diet. And actually, the majority, so 7 out of 10 patients, either had advertent or inadvertent gluten exposure. So adherence is certainly a challenge, and that's why I suspect that yourselves that you look for reasons of how we can monitor adherence. So I think Nick has already touched upon this a bit this morning, but this is really an interesting slide, and I think it's a really important one from this talk, and it's looking at serology in terms of assessing adherence. And what you'll see from this landmark study was that the sensitivity or pickup rate using TTG or endomycin antibodies for changes of celiac disease or villus atrophy was only 50% or less. Essentially, that's like flipping a coin. And I mean, personally, in my own practice, I do serology, but after having seen this study, I'm now more aware that actually serology is not a good marker of adherence in patients with celiac disease. So if serology isn't great, then what options do we have? Now, if you look at the table on the left, this is a study by my colleague Michelle Lau, who looked at other non-invasive markers of adherence. So she looked at a test called the Symptomax test, which is a point-of-care test, which is a blood test. And that sensitivity was slightly better than serology at 67%, but still wasn't great. And also we have those validated questionnaires that sometimes you might use in clinic. And again, the sensitivity of these tests were poor at only 25%. So you can see that actually we don't have any good non-invasive markers of adherence. And as it stands, the gold standard must be duodenal biopsies. And the reason why I say that is that mucosal healing is really important in these patients with celiac disease, because we know that if you have ongoing inflammation, ongoing villus atrophy, you're increasing your risk of long-term complications such as small bowel lymphomas or cancers. So I've said that there aren't any non-invasive markers at the moment, but is there anything on the horizon? Well, there's something that we're using here in Sheffield, and I'm not sure if any of you have actually used this yourself in your centres, but we're using something called urine peptides. So these are tests to see whether there's actually any gluten in the urine, so we can assess whether a patient is adherent to a gluten-free diet. So, how does it work? Firstly, a patient just pees in a pot, and then what we do is we send it to our labs. After that, they then take a small sample of urine and put this on this strip. So it's just this area here. And what you'll see is that we wait 15 minutes and then we get a result. So if there's no gluten in the urine, then you'll get a negative test, which will just be that simple green bar. Whereas if there is gluten detected in the urine, then you get a red bar on top, as seen there on the right-hand side. So it is quite a simple test, only takes 15 minutes, and it's pretty easy to use. So the real question is that how does this compare to biopsy? Because I keep on telling you that biopsies are the gold standard. So this is a study from Spain where they looked at the urine peptides and compared it to changes on duodenal biopsy. And if you look at the left-hand side of that bar chart, so these are Marsh 0, so those with healthy, normal-looking bowel, you'll see that the vast majority actually had negative GIP. So that means they had negative tests for urine peptides. Whereas if you look on the right-hand side on the bar chart, you can see that the majority had positive GIPs. And these were positive for gluten in the urine, and that correlated with Marsh 2 or 3, which is indicative of mucosal changes with celiac disease. So you can see actually that maybe we might be able to use urine peptides in the future, but this is only one study, and I think we need further studies before we can validate this and use this in our clinical practice. But who knows, maybe these peptides will be coming to a clinic near you soon. So now I'm going to talk to you a bit about portable gluten testing. So some of you may have already encountered this before, but this is freely available to patients. So this device I'm going to talk to you about is something called NEMA. So this is a device that you can find easily on Amazon, and what it does is it tests food products to see whether they have gluten in them. And because we live in the digital age these days, individuals can upload the results via a smartphone app, and they can share that with other users as well as the manufacturer. So a group in America have actually used this data from NEMA users, and what they wanted to see was, are gluten-free foods in restaurants actually gluten-free? So if you look at the table on the right, what you'll see is that about a third of gluten-free foods in restaurants actually had gluten detected in them using the NEMA device. And interestingly, it seems that pizza and pasta were the worst offenders. So gluten-free pizza and gluten-free pasta, about half of those products tested actually had gluten in them using NEMA. So you might say after this, well, if you've got celiac disease, can you really go and eat out? And can you eat gluten-free pizza and gluten-free pasta in restaurants? So this could be potentially concerning looking at these results. However, I think that we need to take these results with a bit of caution. I think there are a number of potential limitations of using these NEMA devices. Firstly, we're not sure how accurate they are in terms of sensitivity at the level of 20 parts per million, for which we know is the standard for gluten-free food packaging. And also, we know that the NEMA device can detect gluten at levels of less than 20 parts per million. Now that is a real worry, because let's say I go out, I buy a gluten-free product that is less than 20 parts per million, the NEMA device may come back and say that it's positive for gluten. And that's going to lead to a lot of anxiety for patients, and it may lead to the development of obsessive behaviors and orthorexia nervosa. So whilst there is a smiley face on a NEMA device, maybe we need to add a sad face, but I guess only time will really tell. And I think the final thing to mention about these devices are they're not cheap. To buy these online, it costs over £200. And actually, when you're testing food products using the capsules, each capsule is £5. So if you're going out and testing 2 or 3 products in your meal, that's going to cost you £10 to £15, which is probably more than the cost of the meal itself. And I suspect this is going to be used by the most anxious individuals who probably already have tight control, as Nick has mentioned, and also it probably be used by the wealthiest individuals. So this table at the bottom of this slide is from the American study, and what they note is about 2/3 of these individuals are from the highest income quartile. But I suspect that you're going to see more and more of these patients in your dietetic clinics. So finally, I'm just going to talk to you about persisting symptoms and how we should manage these patients, which I think Nick has touched on slightly as well. So this is our algorithm from our national centre here in Sheffield of how we manage patients with persisting symptoms. So what I want you to do is just look at the top of this slide, and what you'll see is that the first thing that we do is that we make sure and establish that this patient actually has confirmed celiac disease. So we'll have a look at their bloods, we'll check their histology, and we'll check their genetic typing if it has been done. Now, after that, if they have a confirmed diagnosis of celiac disease and persisting symptoms, we move on to the next part of our algorithm. And this part is really important, and it's been touched on already today, but these patients need a repeat gastroscopy and repeat duodenal biopsies. I don't think that we can label patients as being functional without doing a repeat biopsy, because we don't know whether these patients have ongoing villus atrophy or not. And also at this stage, we think of other diagnoses outside celiac disease. So if they've got ongoing diarrhea, for example, we might think, have they got microscopic colitis? So we'll organize a colonoscopy. Or have they got malabsorption? Have they got pancreatic exocrine insufficiency? Should we do a fecal elastase test? So there are a number of tests that we do at this stage. And after that, if the patient still has ongoing mucosal changes or persisting villus atrophy, then we would get our dietitians here involved. And at that point, we would assess for adherence to a gluten-free diet, about inadvertent or advertent exposure. And as Nick mentioned, in rare circumstances, we may consider a super-sensitive gluten-free diet. And also, as Nick's mentioned as well, that some patients are just slow healers. And if after all of that, these patients still have ongoing villus atrophy, then they may have refractory celiac disease. So we looked at our patients with persisting symptoms here in Sheffield to see what the outcome of these patients were. So we have about 2,500 patients on our in our centre, and out of those, about 300 or so presented with persisting symptoms. So this next slide shows you what the outcomes were for these patients. And you can see it's pretty varied, and actually not everything is due to celiac disease. So you'll see there's some diagnosis of IBD, microscopic colitis, H. pylori gastritis. So it's quite wide in terms of diagnosis for non-responsive patients. I think the thing to highlight is that adherence was accounted for about 22% or so, and that's why it's important to have ongoing dietetic input. And also the other area that's important to mention is about functional or IBS symptoms, which again was a relatively large proportion at about 19%. And for these patients who are functional, as Nick says, they may benefit from dietary therapies, including things such as first-line dietary advice or the low FODMAP diet. But again, the thing to highlight here is that these patients have all had a repeat gastroscopy, which shows that the mucosa has healed before the diagnosis of IBS, and I think that's really important. So, to summarise, I think that biopsy avoidance may be the future for adults with celiac disease, and I say select circumstances. I suspect it would be similar to like the pediatric group with high TTG titers. I think for those individuals with potential celiac disease, so those who have positive serology without confirmatory histological changes, I think that we should give these patients the option of a gluten-free diet. And in terms of adherence, I think biopsy is the gold standard as it is, and I don't think we can use serology as a marker. And I think if someone has persisting symptoms, we could always think outside the diagnosis of celiac disease as well. So finally, I'm just going to mention the same thing as what Nick mentioned about our dietetic survey. So I'd be really grateful if you could complete that. I think the break time is a good opportunity to do that. Thanks very much for your time, and I'd be happy to answer any questions.